Thank you for joining us today, where I think it's a great time to be talking about MRCP PACES, and the aim of this webinar really is to give you an idea of MRCP PACES exam, as well as how you can revise and what the tools for revision are. By means of introduction, my name is Dr. Matt Lee. I'm a doctor in London. I completed my medical training and internal medicine training in London in the UK. Worked at various hospitals, including St. Thomas's Hospital and UCLH. And I am an academic clinical fellow with integrated training in clinical oncology in London as well. Some people may know me from a couple of the other hats that I've had over the last few years, most notably that when my MRCP journey started many years ago, I think it's almost half a decade ago at this point, I was frustrated by the resources that were out there. And after I finished part one, I ended up making a resource of part one that I was really, amazing, grateful that a lot of people found useful and resonated with, and have continued to do that up to this point, and had the opportunity to work with Pastest for various resources, as well as for PACES in this webinar, which I'm very grateful for. Aside from that, I also wear a couple of other hats in terms of research. I have a particular interest in cancer, AI, digital health, and I previously worked at NHS England as well. So, cut down a couple of things, but really one of my huge passions is about medical education, and I'm passionate about sharing experience, being able to share what I've learned, and any sort of things that I found helpful, things that I've not found helpful, just because I know that medicine and the exams are a very lonely journey, and I think it's very helpful for that kind of collaborative nature. So today, the main things that we're going to be covering, really, because I know that I think we have participants from many different countries, and I imagine people from various stages. I know quite a few people are getting ready to sit the MRCP PACES exam in the sort of next few months, but I know a couple of the people joining this today are also a little bit earlier. So they may be foundation trainees, they may be trainees from abroad, who are just in their intern year, or maybe something that you are just thinking about, as a medical student. And so what I'd like to do is I'd like to give you all sort of the introductory, a brief introduction on the exam itself. And so this will be helpful to ground your understanding of the exam, and it consolidates if this is something that's a little bit in the nearer future. After which we will go through revision strategy, sort of how you revise, what you revise, what resources to use. And I'm going to take you guys through a clinical case with the online resources, just to illustrate to you how you can approach a case, the different things you need to be thinking about, and what revision materials you can use along that pipeline. Okay, and then I'll tell you a little bit about what I've done and what you can do taking forwards. And finally, I'd like to leave some time for question and answers. I won't be able to access that at the moment, just because I have this on my full screen, but I will leave ample time just to answer any questions about the exam itself, about revision, and anything else. And obviously, you can reach me offline afterwards at any point as well. But I will sort of go back to the chat. I know I think there might have been a few comments already, but I will go back to that, and to the Pastest team, if there are any issues or technical issues at any point, just feel free to unmute or drop me a message, and I will try my best to fix it. Perfect. So let's just crack right into it. MRCP PACES, obviously a very difficult exam, notorious in its reputation as a very, very challenging exam, partly because it's such a unusual exam. Some people may have done OSCEs or objective clinical assessments in medical school or in earlier years, but really this is a more challenging step up. And I'm sure many of you have spoken to seniors who've done the exam before, and there are horror stories. When I was studying for the exam, I heard about crazy diagnoses, really unpredictable cases, really harsh examiners, and people coming out crying. And that definitely scared me off at the very beginning. Aside from that, though, it's it's really difficult, a very different of an exam because of how different it is from part one and part two, both in content, nature of the examination, not being a multiple choice question, for example, and also what exactly it examines. A couple of things primarily, which is it's a lot about physical examination, identifying clinical signs for the first time. So not just about your knowledge, but how you apply and how you maneuver and work with the patient to identify signs, and then how you wrap that up in real time, like you would in a hospital real case or when you're seeing a new admission in the hospital, to think of what the differential diagnosis is on your feet, thinking quickly, and be able to present that in a succinct manner. So it's not only about your clinical acumen, but it's about your demeanor, your approach with patients and examiners, and how you're able to illustrate the story that you're telling in a convincing fashion. Obviously, that comes with a lot of information that you need to know beforehand. However, having said that, part one and part two do a fantastic job if once you get to that stage of actually giving you most, if not all, the information you need to pass the exam from a theory perspective. So a lot of it is really just about the practical aspects, which I'll go into a bit more detail. Fundamentally, you can take the exam after you've finished part one. You don't have to have done part two before you do the PACES exam. Technically, they're both part two. They're labeled as part two PACES and a part two written. So you can do either before or after, but the MRCP statistics show that people who've done part two before sitting PACES and those with 36 months of experience tend to have higher pass rates. And this is simply just because I think people just have more clinical exposure and have been working for longer and seen more clinical cases. So they are a bit more comfortable with clinical examination findings and are able to wrap their heads around it together simply because they've been doing the job as a doctor for longer. The PACES format changed in 2023. And so the old PACES format really at this point is not important, but it is helpful just to be aware of it, just because some of the resources that you'll find online historically will be catered towards the old format. So just be aware when you are looking for resources. Textbooks in particular will describe that. So just make sure you're aware of it. Basically, the examination consists of 5 stations rotating. On the real exam day, there'll be 6 stations. There'll be 5 stations on a rest station, and you'll randomly start on a station and rotate through. And you don't get to choose which station that you start. So you might start on a station 1 or 5 or 3 or whatever. There are 3 types of stations. Clinical consultation, which now take the 20 minutes and include a full history examination and presentation. There's a history taking station. There's a clinical examination station. There's no history taking station now. That's a different thing. There's a communication station, an ethics station, and then finally there is the clinical examination station. And there are 4 clinical examination stations: respiratory, cardiovascular, neurology, and abdominal. And you'll see that they are split in slightly different ways on the carousel on the image in the bottom right. So the communication station in station 1 is paired with respiratory. Station 3 is 2 clinical examination stations, so cardiovascular and neurology. And abdominal station is paired with communication station in station 4 as well. Okay, so the short takeaway from the change in the PACES format is the consultation stations have changed from 10-minute stations to 20-minute stations, which means that there's more time to take history, and that does change the differential diagnosis actually of what comes up, because it's not a spot diagnosis anymore. It's a history examination and go from there. And the history examination, which previously was its own station, has been removed in its entirety and has been integrated into the consultation station. Some people prefer it, some people don't. I think it's a change that reflects real world practice, because as medical doctors, we are commonly in clinic, and the clinical consultation is more reflective of a real clinic consultation rather than them being isolated. Now, when it comes to passing the exam, it's really, really helpful to know how exactly the exam is marked, because then you know how you're going to get your marks. And this is something that I'm a big advocate for in terms of how to approach exams and since medical school, but also part 1 and part 2, thinking about the mark distribution. Very much similar strategy here in PACES. There are 7 key domains within the exam mark scheme that are assessed. The mark sheet that you will be given on the real exam day is seen on the right, that the Royal College of Physicians UK mark scheme. This is just the one for respiratory station examination. You'll fill in your examination number, sensor number, and so forth and so on. And then the examiners will mark you based on 7 skills. And the skills do differ depending on what station you're in. So for example, you may not be marked for certain things like a differential diagnosis in a communication station, for example. So it does differ slightly. The marks are all marked at 2. So for every examiner, and there are 2 examiners per station, you'll either be given a mark of 0, which is a unsatisfactory, a 1, which is a borderline where you've gotten some stuff right, but not all of it, and satisfactory, which is 2, which is essentially that you've met the required benchmark. And just for your reference, which is helpful to know, at the beginning of the session, the 2 examiners will meet before the examination starts for the candidates. They will examine the patient independently, or they'll take a history independently, and then they will decide what is the minimum things that they need to pick up. So clinical signs, for example, what have we picked up that we would expect examinee or candidate to pick up? And then they will say X, and Y, and Z signs will give you a 2. If they don't pick up the key sign, but they do pick up some other stuff, that's a borderline. And if they just don't pick up any of that stuff, it's unsatisfactory. And they will calibrate that with the patient and the real clinical signs on the day, and with each other, so that it's fair and standardized across all the candidates that go through that station on the day. There are 2 criteria for passing the exam. The first is to achieve the total score of 126. And that's just a summation of the clinical skills. And you can see the totals in the bottom right section. And then the second thing is that you have to pass each of the individual 7 assessed skills. What that means is that you have to be able to meet the certain threshold for each clinical skill, whether that's your confidence in examination, whether that's your clinical communication or clinical signs and managing patient concerns. And as you can see, there are a couple key things to be aware of. First of all is that the 2 skills that I've circled, first of all, identifying physical signs and clinical judgment, are the 2 that are most commonly failed by candidates. The reason for this is that actually, when you're thinking about what exactly the hardest, or what exactly you're being assessed on, or the hardest bits, it's when you approach a patient and you are expected to find all the signs within a certain number of minutes, and you put all those signs together into a constellation, and you have to give a sound clinical judgment, not only of the diagnosis, but also how would you manage and investigate this patient in the Viva subsequently. The other important thing to note is that for these 2, but also all of the other skills, aside from maintaining patient welfare, which I'll go through shortly, there is a bit of leeway for passing, essentially. So for example, for skill B, identifying physical signs, you only need to score 14 out of 24, which is only 58% to pass the overall clinical skill. And what that means is you don't have to be perfect. And if you think about how many stations there are, the key ones for this really are going to be the clinical examination stations and the consultation stations, of course. But it does mean that you don't have to get full marks for every single station, pick up every single clinical sign there is to pass. And in fact, you don't have to pass every single station to pass. You can fail 1 station, you can fail 2 stations at a stretch. And if you do really well on the other 3 stations, or the other 3 sort of rotating groups of stations, then that's still enough to pass. And so if you feel like you haven't done well on 1 station, or you feel like I really missed something on the day, the most important thing is to step out of that room, and you have a minute or 2 buffer period between stations. Step out of that room and just pause for a minute and think to yourself, that maybe it didn't go as well as I hoped, but I still have every chance to pass the exam going forwards. And I know it's very difficult. It's much easier said than done, but you can absolutely pass the exam even failing 1 or 2 stations. So it's important not to be bogged down by that. The last thing to say about skill G, which is maintaining patient welfare, is that this is pretty much a non-negotiable, and that's reflected in the much higher pass mark in this skill than the other skills. when I say maintaining patient welfare, this is very simple things that really ideally should be baked or into your clinical habits, although sometimes can be difficult to remember. And these are things like asking the patient if they're in pain before you palpate their abdomen, washing your hands before every station. And they do actually give a mark for that, or take away a mark for that if you don't wash your hands with alcohol gel or whatever they have available. So make sure that's early on, you're establishing those good habits. But very simple things like your manner, how you maneuver the patient. So for example, if you are flattening the bed in an abdo exam and it's 45 degrees after examining the JVP, you're friendly with the patient and you're asking them, I'm just going to let you know that I'm flattening the bed. And then, you're just very calm and collected and very pleasant. You can only really lose 4 marks for that. So it's important that you have good habits that are built into your approach to patients early on. But generally, having said that, most people don't have too many problems with this because it is just a part of our everyday routine in the clinical practice. Moving on, what comes up in the exam is it's the $1 million question, isn't it? And when you think about the examination stations that come up, the abdo, the respiratory, cardiovascular, and then you think about the horror stories. I mean, I'm not even going to get started about neurology, but the horror stories that you hear from the seniors about crazy diagnosis, crazy name syndromes, and you're sitting there as as a relatively junior doctor thinking, I barely know anything about this condition, and in about 6 months, I'm going to be expected to diagnose it. What am I going to do? In theory, yes, that is true. Anything can come up. But also, I'm going to caveat that by saying that most of the time they don't. And it's important to have a strategy, both in your revision and in your examination day itself, that helps you prepare for things that are most likely going to come up and have a fallback strategy for if it doesn't and you need to approach it, in a slightly different way with whatever rare diagnoses. And also caveat that by saying, if it's a rare diagnosis, they're not going to expect you to make that diagnosis instantaneously, and oftentimes they will guide you, like something really rare or very difficult or very unusual. You have to remember also that the examiner of each individual station is not going to be a specialist in that respective station. So you're not going to get a neurologist in your neurology station. Generally, I think there are exceptions, but that's generally the RCP guidance. So they're not going to know, or they're not going to be experts in the specific gene associated or mutation associated with hereditary spastic paresis or some crazy phenotypical syndrome. They're going to be talking about the basics. And so whilst anything under the sun that is a cardiovascular condition or a neurological condition could come up with clinical signs that are hopefully identifiable, most of the time, and I say 90% of the time, they are classic PACES conditions. And this is why the resources will focus on several conditions generally. And the important thing to know when you're thinking about what to revise and how you approach it on the day, in terms of how you maneuver that differential diagnosis and how your mind is thinking and eliminating diagnosis as you go along, is that there's a huge selection bias in how the PACES cases are selected. Generally, there's a couple of criteria. And when you're thinking about things from the examiner's perspective, for example, you are an examiner looking for PACES cases. And these are usually people that, or patients, people in the community who have conditions with clinical signs, okay? You need to organize this usually a couple months in advance. So you need patients who have great clinical signs right now, but you need patients who are still going to have great clinical signs in 3 months' time when they come to be examined by candidates. You need to know that they're going to come, so they need to be clinically stable and they're not going to deteriorate, so minimal risk of deterioration on the day. And they need to be able to travel to the venue. So really, they need to be able to mobilize, ideally reasonably, with a good exercise performance status or whatever, and then be able to tolerate multiple examinations, which, for example, for respiratory is every candidate asking to take multiple breaths in the front of the chest and in the back of the chest. That can be quite tiring for someone with end-stage emphysema. But but that's which is why essentially they don't usually get the really sick patients. What this means is that actually you can be quite strategic about trying to predict what comes up. And uh, what we found from speaking to many PACES candidates around not most from the UK, but also from countries like Singapore, Hong Kong, India, Pakistan, is that oftentimes the common stuff is common. And the top 10 conditions for each station represent 80 to 90% of the cases almost most of the time. And fulfilling that criteria often will mean that they are chronic conditions like bronchiectasis, murmurs, or neuropathies. The left here are the assimilated findings of the common cardiovascular conditions that we've put together. And this is really helpful because it allows you to guide how you revise. It allows you to guide what you feel like you need to know. And it also means that you can tailor your revision to be high yield. Because if you know what is probably going to come up 80 to 90% of the time, it makes sense to be dedicating 80 to 90% of your revision to these conditions for each respective station, of course. And the rest of the 10, 20%, obviously you need to be thinking about the rare conditions, but you need to be thinking about, okay, so if I don't know the diagnosis, what is my fallback plan? How am I going to respond? And how am I going to approach the presentation and whatnot? So you have a fallback plan. And you need to remember that these rare conditions, they're not going to expect you to get off the top of the bat unless it's something reasonable. So therefore, it's not about how much you know and how much breadth you have about the really rare conditions or the mutations for specific conditions to impress the examiners. They don't need you to know really scientific findings or up-to-date treatments for multiple sclerosis, for example. What they want to know is that you're going to be a safe doctor. You're going to be a safe medical registrar. And if you are the medical registrar or senior resident in your hospital, that you are going to be able to safely diagnose patients, or at least safely approach, start initial treatment, and have a good rough ballpark of what exactly is going on. And all this information is really helpful because it can tailor your revision strategy to be high yield and to be focused on what you need to know and the skills that you need to know to develop it. So thinking about the last couple of slides that we've just gone through, you know the skills that you roughly need to know and what you need to pass. You know the common conditions. So that was cardiovascular, but we've done the same for other specialties as well. And so when you're thinking about revision, you want to think about what conditions that you're most likely to encounter, and then you think about what these conditions look like. You'll often, you'll likely be familiar with quite a few of them because they're very common medical presentations, but when you're first starting the examination from your bedside, what are you looking for, and what exactly are the clinical signs that you will spot first? So, for example, COPD. The first thing you'll see, in theory, is, well, aside from the bedside stuff like oxygen cylinders, a hyperinflated chest, maybe pursed-lipped breathing. And as soon as you know to look for these two things, your diagnosis becomes much easier. Same for an abdo case, for example. Renal transplants or chronic renal failure, end-stage renal failure. When you walk into the abdominal station, you need to know exactly what your mental checklist is that you're going to be looking for. Because as soon as you see a scar of a certain type, or you see an arm fistula, your mind should be working, the cogs should be turning and knowing, how does this change your differential diagnosis? And what do you look for next? And these kind of reflexes, habits, they can be very much trained when you're revising for the exam itself, miles before you actually come into the exam station. But it helps you to feel more confident on the actual exam day. When you're going in, the nerves are going to be high. You're going to be freaking out about a million things. I mean, I'm not gonna sugarcoat it. It's a difficult exam, and it's also very tiring and very long and stressful. But the best chance that you can give yourself is if you put in the work to be smart about your vision and help you approach in a systematic way on the day. When you think about how you study, I think there are 4 predominant areas that you should be thinking about, which is, how much time do I have? So do I have 4 months, 6 months? How much time within that period am I going to have to study? So, do I have family commitments? Do I have to most of us will be working full-time clinically. How many hours can I afford to revise, and how do I then think about what resources I plan to use? And there are a lot of different resources. It's very difficult to navigate through the different ones, and you often get bogged down with a lot of information about the exam format itself, but also the clinical stuff, some of which is out of date as well. But you just need to be smart with how you use your resources, compiled with your time in the hospital itself. Looking back at your MRCP Part 1 and 2 results are also very helpful because you can identify the specialties that you're particularly weak and strong in. And finally, you have to think about how you best learn, essentially. So are you someone who likes flashcards? Are you someone who is able to absorb a lot of information from practical stuff, presentations, discussions, group work? How does that fit into the resource that you need to revise and the practical skill that you need to develop? And how does that fit into the time allocations and how you want to split your time? So, how much book work, how much home video case review work do you want to do versus being in hospital, physically examining, which has its limitations as well. I would definitely say, and it's important to be aware of, because actually when you're in hospital, you'll find that the yield is a lot lower than you think it is oftentimes, because hospital patients, first of all, they can refuse. Second of all, they can be sick. Third of all, they may not have clinical signs that are typical or good. And fourth of all, you may not be able to perform a full physical examination. And fifth of all, clinical pressures, obviously. So it's important to find a balance between resources. And it's also important to know how to measure progress, because it's not linear. It's not like MRCP Part 1 and 2, where you are doing a question bank. Your rough idea of progress and tangible improvement is measured, or you feel, it's almost like a reassuring, or actually less reassuring, because when it drops. But your percentage of questions correct in each sitting, your average, how does that compare to your friends who passed or failed? How are you doing the mock papers? You don't have any of that on in PACES examination. And so it's very difficult to fall into the trap of, I've examined, I've done X number of hours, but actually that's not the most important metric. The most important metric is how you are progressing in terms of your skills, your confidence in identifying clinical signs, your range of pathologies that you've seen, and the range of patients that you've seen, and also your confidence in finishing the physical examination. So you have to finish it in 6 minutes, essentially. I'm going to take you through an online case, and this one is taken from the Pastest video course. I'm not sure if you guys will be familiar with it, but there are arranged. It's a very well used resource where that holds a lot of video cases with clinical examination presentations and Viva. And I want to give you an idea of a typical case for PACES, but I'm going to walk you through it in terms of how you approach it and a couple of other bits of like presentation and Viva. Okay. The video bank has, I think, almost 100. I can't remember specifically, but close to that, 100 video cases of individual clinical examinations. Okay, and they have they're real patients with pathologies, and it's obviously not the same as examining in the hospital, but it's really, really good for consolidating knowledge and also gives you the benefit of revising at home. So this is one such case, and in the real examination, you'll walk into the room, and there'll be a piece of paper normally above the patient or next to the patient. There'll be a clinical vignette. And so for this one, it's that this elderly gentleman is presented with breathlessness, and it's just asked you to examine and proceed. Okay, so I'm just going to play the video, and this one is a condensed version of the clinical cases. The clinical signs, the positive clinical signs. But you'll have the full video, so it's like you're doing the real thing and you're following along for the actual video case bank. Okay. So hopefully the audio plays, but
hello, I'm Dr.
Let me know if there's issues.
Would it be all right if I examined you?
Yes, of course.
Thank you. May I have a look at your hands? And can you turn them over? May I have a look at your eyes? Can you pull down one eyelid for me? Thank you. And now open your mouth wide and put your tongue to the roof of your mouth. May I feel your pulses? Can you just turn your head slightly to the left and let your head rest back against the pillow? Do you have any pain in your stomach?
No.
I'm just going to press on it. Take a deep breath in. Stop. 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 You're ready. Hold your breath. Breathe in. Breaths in and out through your mouth. Thank you very much. I've finished my examination. You can get dressed now.
Okay, thank you.
Perfect. So that is just to give you a taste of what the examination will look like. And that's a condensed version. So that has primarily shown what the clinical findings are essentially. And that's a quick video to help consolidate. So for example, if you're someone who's just revising at the end, you use the quick case and you try and summarize that into a presentation very quickly. They're the full videos and the full examination. And generally the way a lot of people use it is they'll follow along, they'll pretend that they're doing the examination, they'll listen, so you heard the heart sounds, you heard the breath sounds, they'll listen and then try and present it all at once like it's a real case. And you can get through a lot of these quite quickly, a lot quicker than looking for patients, getting consent in the hospital one by one, and then taking turns with a partner. Just to give you an idea of the clinical examination format, they're all 10 minutes each, and they all consist of a 6 minutes examination followed by 4 minutes, which includes your presentation and some follow-up questions from the examiner. You need to finish your full examination in 6 minutes, and that's challenging for certain examinations like the neurology station, where there's quite a lot to get through. And hopefully you will have a little bit of an idea of what is expected of you in the examination. So the candidate was performing a standard cardiovascular examination that starts peripherally, or rather starts with inspection peripherally to the face and then the chest. Alongside, you may have picked up a couple of clinical findings that were relevant. And I appreciate it's not always the easiest on the screen, but based on what you're looking for and the order, what do you see from the get-go when you're standing from the side of the bed, initially when you see the patient? Are there any obvious scars? And in this case, there was a midline sternotomy scar. When you see a midline sternotomy scar, there's a helpful sort of mental framework to think about how you approach the differentials, which we can go into a little bit later. But you want to be thinking about how you categorize that case. So midline sternotomy scar is probably going to be one of the relevant key findings for this. And there are several differentials for a midline sternotomy. So what are they, and how do you then deviate from that branch to help you differentiate between your diagnosis? Is it a cabbage, in which case you'd likely see a mammary artery graft or a leg harvesting scar? Is it a metallic valve replacement, in which case you would see or you'd hear a click? And in this case, there was a loud S1 on the auscultation of the heart. And that suggests that it is going to be a mitral or tricuspid valve replacement. And it's difficult to appreciate. I know bioprosthetics and metallics both sound loud. This one was a metallic. But I think in this you'd be able to differentiate that much easier in the real thing. But the main thing is that is really these cases are helping you train your thought process. Okay. And then finally, you put that into a succinct package and you present the clinical findings to the examiner. These are a couple of ways that you present the case. And it's important to have a really, really well-structured presentation for each of your conditions, or at least the high yield ones. And this is why it's so helpful to have sort of the list of the 8 or 9, 10 conditions for each station, because you're able to practice a very, very condensed, a very practiced and well-rehearsed examination presentation for these specific conditions, and then adapt it slightly on the day. And so, for example, this metallic valve replacement is pretty much, so first of all, to say a valve replacement structure is pretty much going to be the same, no matter what valve it is or whether it's metallic or bioprosthetic. You're going to comment on certain things, the key clinical findings. You're going to comment on key negatives, which are there any features of decompensation or any murmurs or whatnot. And then you're going to comment on the underlying indication. These are always going to be things that you mention for a specific condition. And so when you build that mental muscle of knowing that as soon as you hear, you're thinking valve replacement, and then it gets a presentation, I have to talk about this, I have to talk about this, I have to talk about this. And when you have that structure, when you're stressed, having that structure to fall back on is really helpful. But also, it means you're prepared, for the actual exam. If it comes up, if it comes up, you're really, you're feeling very confident about the station. Okay. More generally, it's helpful to have a rough presentation structure, which is the one on the left, which is, there's certain ways to approach it. And this is helpful as a fallback, but also if you're not so sure, you present the key clinical findings in order from inspection, peripheral, chest, and then you comment on important negatives like infective endocarditis and summarize and then think about your differentials. So it's almost always this kind of structure, but having a tailored one to each common condition is very, very helpful. And then we move on to the Viva part. And there's a little bit of strategy, or at least a little bit of prediction here as well. Because when you think about the stories, and also a lot of the textbooks will give you really, really difficult questions. You have to remember that the examiner is not going to be a specialist most of the time. And so the cardiologist is not going to know a huge amount about seizure antiepileptic, like third-line antiepileptic medication, or the latest drug treatments or drug trials. What they want to know is, are you going to be safe? Do you know what the diagnosis is? Do you know how to start the initial treatment? Do you know how to predict severity? And maybe a couple of relevant things around that you can predict pretty much. The common things really are listed here, and it's things that you can really prepare for when you think about what the common conditions that are going to come up. For the less common conditions, there's even less of a reason for them to ask about specific questions about that condition, because they are most likely not going to know it as well. So they almost always deviate to the common questions like, how do you manage, what investigations, how would you approach this patient if they present to A&E? Those are the things that are commonly assessed. And you have to remember that they're only 4 minutes. That includes your presentation time. And when you're doing the presentation, that by the time you finish, it's pretty much already a minute and a half, 2 minutes. So there's really not that much time at all to answer questions. It's helpful to have resources or a way of revising for these questions. Some people like to write them down into a Word document and then revise that intermittently. Some people like to use notepads. Some people like to use flashcards. Flashcards, for me, I'm a huge advocate. I've been using Anki since medical school, and I found it very helpful to have all that information there, because first of all, I can search it. Second of all, I can revise at intervals. And the way I used it was pretty much, on a commute home, or when I'm just I'm heading somewhere and I've got a little bit of free time, I'd pull it out, do it, and then I would practice saying it, or I'd say in my head if I was in a public space, and practice presenting that question's answer there. And it's helpful to have a deck for each specialty, just so you know the common questions all together. I've talked a little bit about the format, the exam itself, the revision strategy, and what to expect in the case, and how you can approach the clinical examinations. It's really, really helpful to think about how you study. And it's oftentimes very, very challenging to navigate, because as difficult of an exam as PACES is, there's really very little guidance that you get. You speak to seniors, speak to consultants, people give you their experience, and then you're sort of left to figure out, what do I study? How do I study? How do I get this information? How do I use the online video cases? Do I need to go to a course? How do I split my time between examinations? People tell you how to study, but people tell you what to study, but very rarely do people tell you how, and how to make sense of everything. And resources revision is very, very variable. And it's quite easy to be overwhelmed by books, videos, and courses. So it's really important to be tailored, strategic, and focus on high yield materials, so that because you're working a clinical job already, you still want to have time to revise, but you also want to have time, downtime outside of your work, to spend time with family, to avoid burnout. I think these are really important, and your time is very valuable. So making the most of your revision time is also really, really important. I found in my personal experience that revision can feel unproductive when you're in the hospital. The number of times I've been turned away from patients because they just don't want to be examined, or this is like the 7th person in the day that's revised because they have some amazing sign, or they're sick, or they are not by the bed because they're having a scan. And I've wasted hours doing that. And I think that it's very easy, and a lot of people will have that same problem, but it's easy to avoid to a certain degree as well, to help maximize your time. And finally, it's just hard to know really how you're progressing without sort of any tangible metric. And I had these same problems when I was revising all that time ago, and found very little guidance. And that brings me on to the course I've developed. And really, this is an embodiment of the years of experience that I've had with developing resources. And I'm not saying you need to get this. I'm not saying that you'll definitely pass with this, but really, this is I put this together in the same way and the same reason that I put this the part 1 resource together, because I wanted to give people a strategy and a way to pass their exam with a little bit more confidence and a little bit more strategy. I think that there's a lot to be said about how you approach the exam that isn't taught very well, if at all. And I spent a lot of time trying to diffuse that and really study it to the best of my ability. And I feel like I finally found a way that I've been able to help some other people with starting with the candidates that I've supported with the guide already. It's basically everything that I wish I had in my examination process. All the information with the videos explained, revision guides over 100 pages long. And I mentioned a couple of other things during the talk that would be helpful for your revision that you don't have to use mine, but it's helpful for you to make as well. Things like flashcards with the right information, correct, up to date, as well as high yield content focused around specific high yield conditions and the common conditions. It's very helpful to have all that in one place. And finally, it's just helpful to have a strategy in terms of something that's worked for other people before, or a lot of people before. So a month-by-month revision strategy guide with metrics that will help you focus on things that you need to get better on, give you an idea if you are getting better or not, as well as think about how close or what resource to move on to the next step. So for example, when do you start thinking about flashcards? When do you start integrating the video cases? How do you use the video cases efficiently? And how do you then think about the clinical strategy of when you walk into a station, what exactly you're looking for? Just to illustrate a little bit more on the case, things that are helpful to think about, and I have included in the guide, really are strategies around how you approach every step of the examination. And so I went on a lot about the mental checklist and the inspection, and I do go into a lot of detail about that because I think it's the number one most important thing in the examination. And there's a huge amount of strategy that you can do, almost like a checklist of sorts, so you know that you're not going to miss key diagnoses, and it's also going to help you pick up the key diagnoses very early on in the examination. Because if you have that inkling in the first minute or two of the 6 minutes, then you know what to look for in the chest or the face, and you're already thinking about those cogs that of how pulling up that mental muscle in your head of that presentation structure that I practiced 1,000 times for COPD or renal replacement, okay? And so, for example, when you're thinking about scars on the right side here, I talked a lot about the midline sternotomy scar and a mental framework for you to approach. This is just one of those things that are really helpful. But if you know roughly what the diagnoses are, as soon as you see that midline sternotomy, you're looking at the leg. Do they have a bypass graft? You're looking at, you're listening by the bedside. You're putting your head against the chest. Can I hear a metallic click? If I can't, are they a young patient? If they're young, then is it congenital heart disease repair? If they're old, then is it a bioprosthetic valve replacement? In which case, I'm listening very, very closely when I'm auscultating and listening for a loud heart sound to suggest a bioprosthetic valve replacement. And that then bridges its way into the rest of the clinical signs, because you're then looking for peripheral stigmata of endocarditis. You're looking for ecchymoses from anticoagulation with a metallic valve replacement. You're looking for evidence of decompensation. So there is a lot of strategy to be had about each individual station, not just for cardiovascular, but how you approach these stations as well. And of course, you need to have a very structured examination approach as well, to know exactly what you're doing in each step, and also the order that generally the examiners prefer. There's a little bit of strategy around that as well, which is that, for example, the respiratory, whether you start at the back or the front of the chest, whether you need to do vocal or tactical vocal fremitus, you only need to do one essentially to pass. You don't need to do both. It's a waste of time. I was told that by an examiner, by the way. It's not my words. And just things that you need to make sure you're not missing essentially. So I felt it was helpful to have all that in one resource, which is what I've done. And the most important thing to know is that you're focusing on high yield revision. So you know what the most common conditions are, or we know because we've spoken to hundreds of candidates, and our revision is focused around those high frequency conditions. So you'll be super confident in these ones and picking up the signs and then bridging that to presentation. And you also have a fallback strategy. So if you don't find a condition that or it's a 10 or 20, 15%, you have trained a strong ability in identifying clinical signs, and you have a structure, a general presentation, a general examination structure to fall back on, where you just talk about positive findings, negative findings, and report, what you have. But there's a sort of approach that you are well tailored and well versed in as well. And just to reiterate as well, just knowing what you're looking for and how that differentiates or how you navigate through that those constellations of signs based on previous signs as well. So when you're looking for heart sound, what are the key things that you're looking for, and what are the key things that you need to report for a murmur, for example? What does it mean? I think you can go through a million textbooks and things are very scattered, but having all that here in one place will just save time, and it's just clinically, I think it's just helpful as well. At least I found that when I was revising. I won't go through too much detail about what's included because I want to get onto the Q&As, and I'm really keen to answer some of your questions. But essentially, everything I've talked about today in terms of revision materials, things that I think that I would have benefited from, or people that have said, I really wish that there was a document with mnemonics. I really wish that someone could tell me what I need to be thinking about each month and develop a checklist. And I really wish that someone had told me what clinical signs I need to be looking for, or flashcards with the Viva questions. One of my most common things for part one was the flashcards. Most common sort of request was my flashcards. And I didn't have that ready for sort of distribution because it was like very much like a personal thing that was very specific to my knowledge. But for this one, this is a complete set of flashcards that will be helpful, I think, for anyone approaching the Viva section. And it's, it's something that I've really enjoyed putting together and testing and working with candidates on, all sorts of resources that will help, hopefully, with your diagnostic thinking and how you approach the examination, both revision but on the day. Also explains key concepts, but more importantly, it links straight back into the Pastest resources, which, if you haven't used already, is one of the key resources for passing PACES. In my hospital, I don't know anyone that didn't use the Pastest ones. I'm not saying that because I've developed this course with Pastest. I developed this course with Pastest because everyone used their resources, and I know how much they believe in these high quality resources. And being able to reference clinical examinations from the video case, show clinical signs, and explain that in a video has been very helpful. So this is just a quick screenshot of what it looks like in the actual the video course itself. Have a look at my website, mbklee.com, because I have written a lot of stuff about part one, part two, if that's where you're at the journey. There's no paywall behind that. I've put it out for free for years, starting from medical school, just because I'm really passionate about being able to share my experiences, but also the people that I've been able to support in their own journeys. I hope this has been helpful. I think there's so much to be said about PACES, and it's very difficult to cover everything within 1 hour. But just to summarize, it's a difficult exam, notoriously, but with the right strategy and the right approach that starts from your revision, I think it's absolutely possible to maximize your chance of success. And I'd love to be a part of that journey. So if you're thinking about getting some resources that will really help you make the most of your time, make high yields, turn your revision a bit more high yield, then feel free to give it a try. And I'd love to hear what you guys think, or if you have any specific comments as well. So thanks for listening. And I will now try and load up chat to have a look at the questions. So I have the webinar chat now open, and I'm gonna take the Q&As now until I get told I have to stop. I will go. I don't know if you can thumbs up questions here, but I will just scroll to the top. Okay, cool. So I'll just go down the list. Perfect. I'll start with Daisy Manning's question. The example breathless is the presenting complaint. In this example, do you know you're doing the cardio station before the start? Yes, you do. You'll know what number of station that you go into. So it'll be labeled 1 to 5, and you'll be told what exactly it is. What will also happen is certain stations, you'll get a prompt outside of the station. You'll have to sit there for a minute. The ones that you get a prompt for are the communication and consultation stations, and you have a minute to prepare for that. You can scribble notes and bring the note in. So there's a strategy around that as well, which I do cover in the guide as well. But there's a strategy around how you can make the most of your 1 minute, and you actually within that 1 minute have time to write your whole plan of the presenting complaint. The examination stations you don't, but you know what station you're starting on essentially. Is the Pastest question bank and this course more than enough to pass PACES? Once I buy the course, is it for lifetime with my account unlimited? So thank you. The Pastest question bank is, so the Pastest question bank, first of all, is one of the most important resources that you can use. And I'm saying that as someone who is, an internal medicine doctor. The reason why it's so widely used by candidates is because they have captured a lot of pathology, including the rare stuff that you will less commonly see in the hospital, things like polio or various specific conditions. They've brought in patients and recorded the full examination. So you see rare pathologies, first of all. Second thing is that you see a gold standard examination, presentation, and Viva for the common conditions as well. And the third thing is that it's just the convenience of the revision material itself. So you're able to, first of all, revise from your home. You're able to revise in your own frequency and time. So, you can do it at 9 p.m. You don't have to be in the hospital at 9 p.m. or wake patients up, and you're not going to get turned down. Now, I have to caveat that by saying it's not enough by itself, because you still need to be in the hospital examining patients. Nothing replaces physical examination and picking up clinical signs as you're going along. I think the muscle memory of the hands, the arms, the eyes being trained to see what you're doing is very important. Okay, so you have to do that together. In terms of other resources, I do go into a little bit of detail around the specific materials. There are things like books, in-person courses, videos, podcasts. I would say nothing else really is absolutely mandatory, and it depends on your learning style. So some people like to listen to podcasts because it gives you gold standard presentations, so you can listen to it when you're on the train or on the way to work, so your head gets used to the presentation style. Some people will like to read books because they want to read the clinical information, and that's not a bad idea to have one or two resources that you can refer to with the correct clinical examination or clinical information. So it's entirely up to you. But I would say the question bank and the course will very much get you started, and you can always pick up a book or two in the library. A lot of people like courses as well, but I know it's not always accessible. And once you buy the course, I think it's for 6 months. The course, the revision structure that I provided and written is a 4-month, month-by-month revision guide. So hopefully that gives you a little bit of buffer beforehand, just to think about how you're going to implement it. But yeah, thanks. And hopefully the Pastest team can give you a bit more information about the actual subscription itself, because I've just been focused on the clinical stuff. In the clinical consultation station, will there be a wall clock? Because how much we practice on the day will fly while talking to the patient, and it will be difficult to understand when 6 to 8 minutes are completed. Thank you, Anshu, for your question. There is no wall clock. There is a suggestion and a recommendation to bring a clock of some sort, probably attach it to your belts or your trousers or something, like a digital watch that you can start the timer for. Generally, by the time you get into the examination, you'll be quite well rehearsed, so you'll have a rough idea of when a certain amount of time has elapsed. At least your mental sort of judgment will be able to give you an idea. But I brought in a watch onto my that I put on my trousers that gave me an idea. And before I went to the station, I also did sort of divide how I wanted to split my time. So, for example, you know what you need to get through. You need to go through history. You need to go through a full, not full examination, by the way, just a partial examination, relevant, tailored examination to the presentation. You need to do ideas, concerns, expectations. That's a huge part of the consultation station. And generally, they will always have some sort of complaint that they want you to follow up on. So, for example, for a station with diabetes, a follow-up, they were very worried about peripheral neuropathy, and they would have wanted you to offer a lower limb examination, but you wouldn't have needed to do that. But if you didn't get that, if you didn't elicit that concern from the patient, you would have lost a mark, essentially. But you'd want to split it like sort of 5-6 minutes for history, 5-6 minutes for examination, 3 minutes for explanation, and 2 minutes for ideas, concerns, expectations. And that's something that you can practice. Hope that was helpful. Prep time on average for IMG. Thanks for your question. I think it differs for each individual. And I think it also depends on where your strengths and weaknesses are and what specifically you think that you will be focusing your time on. The clinical part is hard, but I think there are also more components to it, because communication is also a very important part of it. And that includes communication techniques, for the one station, the communication station and the ethics station. And oftentimes, if for those especially whose first language isn't English, it can be quite difficult to train yourself to speak in a very empathetic tone, or come across as giving sort of that kind of advice in the way that people want it to be. And that can take a little bit of time to develop. Generally, I think 4 to 6 months is more than enough. 6 months, really, I wouldn't stretch it longer than that unless it's very light work, just because you don't want to burn out as well if you're revising quite intensely. But I would definitely have a think about where your strengths are. In the course, I do give you a breakdown of the specific station types and communication, and I think that makes it easier for people if you try and categorize the case into certain stations. It's also helpful to know what kind of language and terminology that you're thinking of using, and I do have that in the booklet as well. I know that's not very helpful right now, but just thinking about tools and stuff that that might be helpful for helping you pass. Language, terminology, really important. Overall approach, but also trying to predict that station as well. So make sure you spend enough time on that. Would this video be uploaded onto your YouTube channel? I'm not sure. I know Pastest have a copy. I will have a chat with them and see if that can be uploaded onto the YouTube channel. If that's helpful, maybe just let us know in the comments. And I don't know specifically where or where this will go, but it will be recorded and placed somewhere, I know. All the materials for PACES that I've developed have been affiliated with Pastest for PACES. I did a lot of revision materials for part 1 and did some stuff for part 2 as well. But I really wanted to formalize the materials and tie it quite closely with the video cases, just because I found that to be the most helpful thing. And I think that the collaboration with Pastest has really helped me to be able to deliver that. So for the PACES revision materials, at least in this instance, they're currently still associated with Pastest. But if there's anything else in specific that that any of you think will be helpful, feel free to let us know today or afterwards as well. I'm just looking at your question now, Helen Addington. Firstly, thank you for that. At the beginning of my PACE revision, big challenge. Yeah, discrepancies, agreed. Yeah. Yeah, so it's not an uncommon scenario where you will be, you'll have several pieces of information that may be different. And it's a common problem with old historical textbooks, for example, and PACES has been around for a long time, but some of the revision books that people still recommend are a bit more outdated. Generally, I would recommend using the newer guidance, whatever is newest. So, for example, for asthma, whatever the newest one is. But also, you need to be aware of the specific preference of your country and your institutions. So, for asthma specifically, there are different guidances, and the NICE guidance and the BTS guidance are different. The reason is NICE's guidance is based on cost effectiveness, and BTS, British Thoracic Society, is based off clinical efficacy. So neither are more incorrect or correct than the other, but you can offer it, and you can caveat that when you're presenting it by saying this is the specific advice. This is what the key finding is. Basil, the difference between the two courses is that the PACES revision online cases are for Pastest themselves are the video courses, and they have the cases themselves. And what I have with my one is the strategy, the materials, the flashcards, the mnemonics. So the video cases are separate. If that's helpful. Yeah, perfect. I hope that answered your question around the two courses. So I think we're going to end it there. I've run a little bit over schedule, and I know it's a Saturday, and no one wants to be spending their Saturday thinking about work and medicine, at least for too much time. I'd just like to say a huge thank you for all of you taking the time out on a Saturday to come and listen. A huge thanks to the Pastest team, who have really been huge advocates of medical education, and just to end it by wishing you all good luck for the PACES exam. It's a difficult exam, but it's also a big milestone, because if you think about it, when you finish, for a lot of people, it's the last stage of MRCP, where you become a member of the Royal College of Physicians. And it's an exciting and important milestone for many people. And it's a mark that people recognize all around the world. So not only aside from the milestone itself, but it does make you a better clinician. And that's why it's such a difficult exam. But it doesn't have to be a terrifying exam, and it's not as terrifying as a lot of people say it is or play it out to be. And there are ways to make it a bit less intimidating by approaching the exam in the right way on the day, but also in your revision. And so I hope that the resources, or first of all, I hope this talk has been helpful in giving you an idea of what to expect and how to study. And I hope some of the resources that Pastest and also myself have developed may be able to help you. I'd love to be a part of that journey. And if it has helped you, or you have any specific other questions, feel free to reach out to me on my website, Instagram, or to the courses at Pastest team for specific queries around the course. And the code will still be there on the top right, so feel free to use that. And thank you for listening. I will end it there. And I hope you all have a lovely rest of your weekend. Thank you.